If you're studying perioperative immunotherapy, this new HCC trial offers unusually rich data, and its small machine learning analysis at the end is a neat AI-era bonus that helps frame where the field is heading. On screen, you'll see the main fields this episode speaks to. Everything from tumour immunology and clinical oncology to evidence-based medicine, trial design, and the growing role of machine learning in perioperative oncology. If you're working in any of these areas, this is definitely a paper worth keeping in mind. Hi everyone, I'm Dr. Susan Heavey, Associate Professor at UCL, and welcome back to Further Reading, where we learn to read papers the smart way, not the hard way. Today we're exploring a single-arm phase 2 trial testing perioperative immunotherapy. That's treatment before and after surgery, using Tislelizumab and Lenvatinib in patients with resectable hepatocellular carcinoma, or HCC. Now, the clinical challenge. Even when HCC is technically resectable, recurrence after liver surgery is incredibly common, especially within the first year. This study focuses specifically on patients at high risk of recurrence, which makes it clinically meaningful. The authors wanted to know, can we shrink tumours safely before surgery, avoid delays, and improve early disease-free survival? The results are encouraging: an ORR of 55.6% by RESIST, a 1-year DFS of 74%, manageable toxicity, and a 20% pathological complete response rate, which is remarkable for this population. And then, as a sort of AI-era cherry on top, they include a post-hoc machine learning model based on 6 routine blood markers to help identify non-responders. It's exploratory, but neatly illustrates where personalised perioperative oncology is heading. The paper sits right at the heart of debates around neoadjuvant and perioperative IO, especially after some high-profile trials in the adjuvant setting failed to show benefit. For beginners, I want to specify that perioperative means around surgery, neoadjuvant is before, and adjuvant is after. And for advanced readers, I want you to keep in mind the contrast with IMbrave050's negative final analysis, which makes the perioperative timing, tumour immune microenvironment, and patient selection even more relevant. Now, before we dive into a panel-by-panel discussion, remember you can jump to papercraft using the chapter markers if you prefer. So before we interpret outcomes, it's worth taking a quick look at who these patients actually were. Table 1 gives us a fairly typical high-risk CCC perioperative cohort. The median age was 58, almost all participants were male, and the vast majority had chronic Hep B. This is exactly what you'd expect for resectable HCC in the clinical setting. Everyone had excellent performance status and Child-Pugh A liver function, so these were physiologically fit patients. Almost half had more than one tumour, and about 45% had lesions over 6.5 centimetres. A small number had vascular invasion, so overall this is a group with resectable but clearly high-risk disease, the kind of population where recurrence prevention really matters. Figure 1A is your classic trial flow diagram. 44 patients screened, 27 enrolled, and 20 ultimately reached surgery. Only one patient had a protocol-defined surgical delay, which is extremely reassuring for a perioperative immunotherapy regimen. Figure 1B is a swimmer plot. Each horizontal bar is a patient with color-coded responses showing complete response, that's CR, partial response, that's PR, stable response, that's SD, or progressive disease, that's PD, across a pre-operative treatment. This regimen appears operationally feasible. Most patients had timely surgeries, and the visual layout makes the variability in treatment duration very easy to grasp. I like this design, it's very clear. Of course, the limitation here isn't in the lovely data viz, it's the fact that it's a single-arm study. We can't compare feasibility to standard of care. Figure 3 introduces the exploratory machine learning component, a TAP-PFN-based classifier, ideal for small datasets. After ranking features using ANOVA, mutual information, and random forest importance, they identify 6 baseline blood markers. That's LDH-ISO, gamma-GT, CRP, gamma-globulin, total bilirubin, and uric acid. The radar plots and confusion matrices show high specificity in the test set, meaning the model correctly identifies responders, but low sensitivity for non-responders. The model can help identify patients unlikely to benefit, which could prevent surgical delays, but it cannot reliably predict responders. This is innovative for perioperative oncology, but it's limited. It's a post-hoc test. There's a risk of overfitting. There's no external validation. I mean, this is nice, but it's early stage work. If you're a beginner trying to read these AUCs, you should know that AUC ranges from 0.5, which is random or a coin toss, to 1, which is perfect, and that AUC stands for area under the curve. So the stats in this paper is exactly the landscape you expect in a feasibility-orientated phase 2 study. We're talking descriptive stats, survival curves, and exploratory modelling. Kaplan-Meier is appropriate, but with 20-something surgical patients, 1 or 2 events can swing estimates dramatically, as you would imagine. The machine learning model required substantial imputation, and the feature selection workflow does risk overfitting. It's still a cool step in the right direction, but we're talking a very early step here. A quick refresher for any beginners here. Sensitivity finds true non-responders, while specificity protects true responders. In perioperative oncology, specificity is usually the more important of the two, because you never want a model to wrongly deny someone a potentially curative surgery. This paper's model gets that part right, which is why its performance is clinically meaningful despite the lower sensitivity. Let's spend a moment on who these patients represent and who they don't. This cohort is 96% male and over 90% Hep B positive, which is highly representative of East Asian and specifically Chinese HCC epidemiology, where HBV remains the dominant etiology and where disease incidence is among the highest in the world. But globally, and particularly in Western countries, the picture is very different. In the US and Europe, HBV accounts for a far smaller proportion of HCC. Recent estimates suggest HBV contributes roughly 10 to 20% of cases, with the burden shifting towards metabolic dysfunction-associated stereotactic liver disease, alcohol-associated liver disease, and chronic hepatitis C as primary drivers. There's also a striking gender gap here. Worldwide HCC is more common in men, but Western datasets show a male proportion closer to 65 to 70%, not the 96% seen in this study. So this trial's male dominant sample reflects Eastern epidemiology, but doesn't map cleanly onto Western clinical populations. Another important distinction is stage distribution. This study includes a substantial proportion of BCLC-B and C disease, that's nearly half the cohort, whereas Western neoadjuvant or perioperative studies tend to enroll earlier stage patients, partly because screening and surveillance are implemented differently and because tumor biology often reflects non-viral metabolic disease rather than HBV-driven carcinogenesis. In other words, the baseline disease biology, immune microenvironment, and recurrence patterns in Western cohorts can differ meaningfully from the HBV-heavy populations represented here. So when we interpret feasibility and early efficacy, it's important to note that the results are most directly applicable to HBV endemic, male-predominant East Asian populations, with a higher proportion of multifocal or locally advanced tumours. Western generalizability will require additional datasets with more metabolic-associated HCC, more women, more HCV-associated disease, and a broader ethnic diversity. Clinically, this study reinforces that PD-1 plus TKI perioperative therapy is feasible in high-risk resectable HCC, aligning with growing early-phase literature showing promising radiographic and pathological responses to neoadjuvant immunotherapy. A 2024 Frontiers in Immunology review notes that ICI and ICI-TKI-based neoadjuvant regimens are increasingly encouraging but still require large multi-center trials with long-term outcomes. It's worth mentioning here, as we said, that this trial population is quite specific to Eastern epidemiology as well. Similarly, a 2024 Lancet Oncology cross-trial analysis highlights strong pathological responses across neoadjuvant ICI trials, but stresses the need for biomarker-guided selection and standardized perioperative protocols before routine use. Major reviews also emphasize unresolved gaps, the need for validated biomarkers, clear timing of therapy around surgery, and thoughtful integration with local treatments. A recent Journal of Hepatology review summarises that bringing immunotherapy earlier into curative pathways will depend on better risk recurrence prediction and safety frameworks. Overall, this study adds an important feasibility signal, but the field still needs definitive RCTs, harmonised perioperative schedules, and validated biomarkers to guide the right patients to the right perioperative strategy. I'll unpack these future directions, especially biomarkers and trial design implications, in more detail on my Substack.